Hello and welcome again to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. I'm Dr. Roger Henderson and I'm one of the GP Notebook study group presenters. Now in this podcast, I'd like to look at one of the most common endocrine disorders affecting women of reproductive age, polycystic ovary syndrome, or PCOS. However, we should now be using a broader term, polyendocrine metabolic ovarian syndrome, or PMOS, to better reflect what this condition actually is, not just a reproductive disorder, but a lifelong metabolic and endocrine disease. Traditionally, the name PCOS placed emphasis on the ovaries and their polycystic appearance, but ovarian cysts are neither universal nor required for diagnosis, but are instead a feature of a much more complex systemic process. So PMOS affects millions of women worldwide, with prevalence estimates ranging from around 5 to over 20%, depending on the diagnostic criteria. And that variability reflects differences in populations and, importantly, how the condition is defined. But what remains consistent is that it's one of the most common endocrine disorders in our clinical practice. One of the biggest challenges here is its heterogeneity, as there is no single presentation. Some patients present with irregular or absent periods, and others with infertility after months or years of trying to conceive. Many are referred for acne, hirsutism, or hair thinning, while others are identified through metabolic issues such as insulin resistance or weight gain. And some women have relatively mild reproductive symptoms, but significant metabolic dysfunction. And it's this variability that causes PMOS to be often underdiagnosed or misdiagnosed. Now, unfortunately for us, there's also no single blood test or scan that confirms the condition. So making the diagnosis here requires a combination of history, examination, targeted investigations, and exclusion of other conditions. So in practice, this is often a diagnosis that's built gradually as different features emerge over time rather than appearing all at once. PMOS arises from a complex interaction between genetics and environment. We know that a family history is one of the strongest risk factors here, and genetic studies have identified multiple loci involved in insulin signaling, ovarian steroid reproduction, and gonadotrophin regulation. But genetics alone doesn't explain it. Environmental and epigenetic influences, such as obesity, early life exposures and lifestyle, modify gene expression and help to show why the severity can vary even within families, or why symptoms may evolve across a woman's lifespan. For me, though, I think the most important modern insight we have is that insulin resistance is central rather than secondary. Around 2/3 of women with PMOS have significant insulin resistance. Plus, and I really can't overstate how important this point is, this can occur even in women with a normal body mass index. This is a key clinical fact that is still filtering through to healthcare professionals. PMOS is not synonymous with obesity, and lean patients can still have significant metabolic disease. This insulin resistance leads to chronic hyperinsulinemia, which has direct endocrine effects. So elevated insulin stimulates ovarian theca cells to produce excess androgens and reduces hepatic production of sex hormone-binding globulin, increasing free testosterone. This then drives clinical hyperandrogenism, including acne, hirsutism, and androgenic hair loss, At the same time, insulin interacts with the hypothalamic pituitary ovarian axis. Increased luteinizing hormone further stimulates androgen production, while relatively insufficient follicle-stimulating hormone impairs follicular maturation. So instead of ovulation, follicles arrest in development, producing the characteristic ovarian appearance seen on ultrasound. But we must remember this is a consequence rather than the cause of the underlying endocrine disturbance. Now, all these processes form a self-reinforcing cycle. Insulin resistance worsens androgen excess, and androgens in turn worsen insulin resistance. Layered onto this is low-grade chronic inflammation, which further impairs metabolic regulation and contributes to long-term cardiovascular risk. And over time, this creates a progressive, multisystem condition rather than a static reproductive disorder. And the consequences of this extend across multiple systems. Reproductively, there's irregular ovulation and infertility, and chronic unopposed estrogen exposure can increase the risk of endometrial hyperplasia. Dermatologically, hyperandrogenism leads to acne, excess hair growth, and scalp hair thinning. Metabolically, there's an increased risk of impaired glucose tolerance, type 2 diabetes, dyslipidemia, fatty liver disease, and cardiovascular disease. And psychologically, rates of anxiety, depression, and reduced quality of life are significantly higher than in the general population, often driven by a combination of visible symptoms, fertility concerns, and chronic disease burden. So looking at the diagnosis here, this is based on at least 2 of 3 features: hyperandrogenism, ovulatory dysfunction, and polycystic ovarian morphology, or elevated anti-Mullerian hormone, after excluding other conditions. But this isn't purely algorithmic. In many adults, hyperandrogenism plus ovulatory dysfunction is sufficient without ultrasound, and increasingly clinicians are recognizing that imaging should support but not define the diagnosis. Having said that, PMOS still remains a diagnosis of exclusion, and conditions such as thyroid disease, hyperprolactinemia, congenital adrenal hyperplasia, Cushing syndrome, and androgen-secreting tumours must always be considered, particularly when symptoms are rapid in onset, severe, or progressive. I also think adolescents require special caution from us here, as normal puberty can mimic features of the condition, making overdiagnosis a real concern. The management is individualized and depends on symptoms and reproductive goals. So lifestyle intervention is foundational, but it should not be reduced to simple weight loss advice. The emphasis is on sustainable changes in diet, plus activity, sleep, and behavior that improve metabolic resilience. Even modest weight reduction can improve insulin sensitivity and restore ovulation, while exercise alone improves metabolic health independent of weight loss. And framing this correctly is important because the benefits extend far beyond body weight. So for symptom control in those not trying to conceive, combined hormonal contraception is the first-line treatment. These regulate cycles and reduce androgen levels by increasing sex hormone-binding globulin and suppressing ovarian androgen production. If symptoms persist, then anti-androgen therapy, such as spironolactone, may be used, though reliable contraception is essential here due to the teratogenic risk. Metformin obviously plays an important role, particularly in those with insulin resistance. It improves insulin sensitivity and can restore ovulatory cycles, though any cosmetic benefits are typically modest. More recently, though, GLP-1 receptor agonists have gained significant attention, as you might imagine. Now, while these aren't specifically currently licensed for PMOS, they do produce significant weight loss and metabolic improvement, with emerging evidence suggesting possible reproductive benefits and improved cycle regularity in selected patients. Within fertility, letrozole is now first line for ovulation induction, with higher ovulation and live birth rates than older treatments and a lower risk of multiple pregnancy. Any fertility care should always be integrated with metabolic optimization, though, because improving insulin resistance and overall metabolic health enhances pregnancy outcomes and reduces obstetric risk. PMOS requires long-term follow-up because metabolic risks persist beyond the reproductive years, and monitoring includes glucose metabolism, lipid profiles, blood pressure, and overall cardiovascular risk assessment. Oral glucose tolerance testing can detect early abnormalities more sensitively than an HbA1c alone, particularly in younger patients or those with early disease. There's also an increased risk of fatty liver disease, sleep apnea, and mental health disorders, all of which may develop gradually and be overlooked without proactive screening. Chronic anovulation also carries gynecological implications. Prolonged unopposed estrogen exposure increases the risk of endometrial hyperplasia, making abnormal uterine bleeding an important symptom that always warrants evaluation. So I think one of the key clinical take-home points about PMOS is that it is not static and its manifestations evolve over time. Hyperandrogenic symptoms may become less prominent with age, whilst the metabolic risk often persists or increases. And this means that a woman's clinical needs in her 20s may be very different from her needs in her 40s and beyond, and this reinforces the importance of long-term continuity of care. Ultimately, though, PMOS is not an ovarian disorder. It's a lifelong metabolic and endocrine condition with reproductive, metabolic, dermatological and psychological consequences. Its diagnosis requires clinical judgment rather than reliance on any single test, and its management requires a combination of lifestyle intervention, pharmacological therapy, and ongoing surveillance. The effective care is multidisciplinary, involving primary care, endocrinology, gynecology, dermatology, nutrition, and mental health services. And the goal here is not only to improve fertility and visible symptoms in the short term, but to reduce longer-term metabolic risks, support psychological well-being, and improve the health of the patient with PMOS across their entire lifespan. So that's a very quick overview of polyendocrine metabolic ovarian syndrome, and I do hope you found the podcast helpful. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you've any questions, comments or ideas for future podcasts. We really do like to hear from you. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening, and goodbye.